So I just wanted to start by saying how exciting this is to be a part of, and I look around the room and see quite a few familiar faces and a lot of new faces, and I take my hat off to the Lung Foundation as well as to Suzanne and to Nigel for organising this fabulous coming together of people who are passionate about... Can you hear me?
No.
Okay. So I won't repeat. But basically, I think it's a really fabulous initiative, and I take my hat off to Suzanne and to Nigel and to the organisers of today, and thank you all for coming and giving up your Saturday mornings to learn more about what is interstitial lung disease and all of the other aspects of today's program. So I think actually this is quite a hard talk to give. Whenever I'm asked to talk about this to different forums, medical students, junior doctors, physiotherapists, nurses, other sorts of people, people genuinely find this a really hard subject to learn about. And this is because it is evolving so quickly. Over the last 5 or 10 years, what we have thought we have known about these diseases is changing at a rapid pace. It's an area of really intense research focus across the world, including in Australia, and so to try and describe what is interstitial lung disease is a massive challenge, and I often have people scratching their heads. So bear with me. I hope that I can make some really clear points on this condition, and at the end, of course, at the end of all of the speakers, I'm happy to answer questions. So in fact, we give this disease, or these set of diseases, very many names. So you might have heard from your various care people, they're calling what you have different names. So interstitial lung disease, ILD, because doctors and nurses and other people like to use 3-letter acronyms. So we all call it ILD for short. But you might have also been told you have lung scarring. Some people will have pneumonitis, interstitial pneumonia. Pulmonary fibrosis is another common word we use. This is a little bit more of a scientific word, diffuse parenchymal lung disease, and lung fibrosis, I guess, is probably the most common term, and their interstitial inflammation. So the point I want to make is that you will be told you have all of these conditions, and you think, which one is it? And the fact is that most of these terms are very similar in meaning. They're not all identical in meaning, but they share very similar sensibilities. So basically, when we talk about ILD, we're covering most of these disease terms. So what does it actually mean for you? Well, you may, or your loved one, I should say, you may have noticed very gradual onset of symptoms. It may have crept up on you over a number of years, and only with the benefit of hindsight, you say, yes, it probably came on around 2007 or some sort of time frame when you may have started to develop cough or shortness of breath. Or then again, some people have very, very rapid onsets of their symptoms. So for the people who it creeps up on, they may first notice that hills and stairs are a little bit more challenging than they used to be. And you think, oh, I'm just not fit anymore. And so you can ignore those sorts of things. And so it's only when it starts to happen more and more frequently and you develop shortness of breath when you're even at rest that you think maybe there's a problem and I need to go see someone about this. Other sorts of symptoms which are not occurring in everybody in this room, but certainly affect some forms of interstitial lung disease, are outside of the lungs. So other symptoms have nothing to do with the lungs, and these are actually all part of some people's ILD. So for example, many ILDs will also be associated with rashes and joint pains, poor circulation in the hands, or Raynaud's phenomenon, you might know it as. Weight loss, people don't even, how could weight loss be associated with an ILD? But it can be a feature. Muscle weakness is also an important feature in some diseases, and extreme fatigue is a really common complaint, and it may again be, oh, I'm just busy, and so I'm just going to ignore why I'm so tired. And of course, with all of these symptoms, a lot of insidious worry and despair can occur, and so this may be the way that you came at this disease without even realising it gradually over time. So Heather's already talked about the statistics in Australia, and what we really come to understand is that we're really not sure exactly how many people in Australia are dealing with an ILD. We know we have some pretty good stats on the more common diseases, the COPD and the asthma. So COPD is a disease that smokers will develop. There's a bit of overlap there between asthma and COPD. You can see, 1 in every 7 or 1 in every 10 Australians will have these very common diseases. And with the ILD group, we're not really sure. And so we can only estimate. And maybe, as Heather said, somewhere between 5,000 and 10,000 people have IPF, idiopathic pulmonary fibrosis, but that particular disease may only represent 20% of all ILD. So we can only extrapolate that maybe 1 in every 1,000 Australians, maybe it's more, maybe it's less, are dealing with an interstitial lung disease. But put it all together, and that's quite a lot of people in Australia. So, as a rough estimate, maybe 25,000, 24,000 people are dealing with this. There are actually a very large number of different diseases that we're talking about. So there are more than 200 different types of ILD. So that, again, as you can appreciate, increases the challenge of trying to talk through this subject and educate people about it. It's a very simple schema is to divide it into the ILDs with known cause and those without known cause. So the idiopathic group, idiopathic meaning unknown. And some examples of known types of ILD, the hypersensitivity pneumonitis. So an example of that would be bird fancier's lung. Asbestosis, you would have heard about asbestosis. It gets talked about in the media. It's a chronic fibrotic lung disease as a result of large exposures to asbestos. People can get an interstitial lung disease with another disease such as rheumatoid arthritis. And there's also certain medications that will also cause ILD. The unknown cause makes us want to know more about them. I mean, not to say that we don't want to know about the known causes, but the unknown is incredibly frustrating. And I guess the classic ILD that is unknown, that's the most common, is IPF. You've heard it talked about. It's an area of great research interest across the world, and with the registry now in Australia, we are learning more and more about this condition. But there are some other types of diseases that fall under this unknown group as well. So, as a doctor, you come at these diseases with a little bit of a more detailed schematic. So this is based on what the guidelines are all talking about. This is what the medical community think about when they're trying to diagnose the interstitial lung diseases. So I apologise for the small print, but just to say that when I talk about the known diseases, it's mainly the ones on the left that you see there. So ILDs of known association, the connective tissue diseases. So as I said, rheumatoid arthritis, lupus, that's a picture of a lupus rash. That's rheumatoid joints. Various other connective tissue diseases like myositis and Sjogren's. All these fairly uncommon diseases are very commonly associated with interstitial lung disease. Certain medications, as I've mentioned, can trigger ILD in some people. So there are some types of antibiotics that have a very rare but definite association. Certain types of chemotherapy can cause this condition. And occupational exposures. And so I've talked about asbestos is a very common exposure that people had to deal with many years ago. So we're regulating that more and more in Australia, so it's very uncommon for people to have large exposures to asbestos these days. But the problem with this disease is that it has a latency of 30 to 40 years. So people who were exposed that long ago are dealing with the disease today. And so we're still seeing this condition. And of course, people from overseas don't necessarily have the same rules and regulations when it comes to personal protective gear. So these are still relevant diseases that we have to deal with in a medical capacity. Also, just a point I wanted to make here is that just because you lived in a fibro house does not increase your risk of asbestosis. Of course, we're always interested in what sorts of exposures you've had, but having sheets of asbestos in your house does not increase your risk. It's only if you've been involved in the demolition of that asbestos or using it in an industrial sense. So this is a very pretty picture. I love I love looking at these. This is what we see under the microscope when we're talking about the diseases in the second column there, the granulomatous ILD. So granuloma is a type of scar that your body makes. Now, this is not common in every ILD, but it is very, very much the hallmark of specific ILDs. So sarcoidosis, some people will know about, and hypersensitivity pneumonitis. So under the microscope, that is what we see in these conditions. And it is your body reacting to something in the environment by forming these sorts of scars and creating scarring in the lung tissue and the disease. And I mentioned the word bird fancier's lung. Pigeons are the natural enemy of the lung, I feel. So a lot of people are, either pigeon breeders, pigeon racers, even, domestic pets. So things like budgies can trigger a hypersensitivity pneumonitis in susceptible people. So it's not to say every budgie owner needs to worry about this condition, but it is well described that in vulnerable people, and it's got to be something to do with their genetics, will have some exposure to birds, and it has to be a fairly large exposure, and will develop a chronic lung disease. So those are all the known diseases. Then there's this very large group of unknown conditions, the idiopathic conditions, and I have highlighted the top one there, which again you're probably struggling to read because of the fine print, but it's idiopathic pulmonary fibrosis, which is the most common of the unknowns. See this group down the bottom, unclassifiable. So there are in any cohort, any group of people with an interstitial lung disease, roughly 10% of people who we can't label. We don't know what their disease is despite all best efforts. And it's this group that can be quite challenging in terms of working out the best management strategy. Within the clinic that I work in, we've done some number crunching, and it is about 10% who we can't give a specific label to. And so what we do in this situation is we try and work out how is the disease going to behave. So we give it a disease behaviour label. So is it likely to respond to therapy? Is it likely to progress with a chance of stabilising? Or is it likely to progress without response to therapy? So we try to work out a disease behaviour label and work out our management strategies around that. But as you can see from this unknown group, it does raise a lot of questions, which is really why there's so much intense research going on in this field. So to diagnose an ILD, I'm just going to briefly mention this because Karen will talk about this in greater detail. But this will be something that you will all be familiar with. You would have told your stories, your personal stories, to so many different doctors by this stage, I'm sure. So they'll be asking you questions like, do you keep birds? Do you have mould in your house? Did you ever work with asbestos? Do you have poor circulation in your hands, or swallowing difficulties, or muscle weakness, or rash? And they'll want to know, of course, about how long you've noticed the breathlessness and the cough and the other sorts of symptoms that are related to the disease. They'll be listening to your chest, of course. They may be looking at your fingers, and this is a picture here at the bottom of something called fingernail clubbing, which is a very big part of a lot of interstitial lung diseases. Scans, you see the scan in the top panel there. So that really the chest CT scan has changed ILD. This, believe it or not, was not available before the 1990s. So in 1980s, they had to work out what was going on with a simple chest x-ray. And chest x-rays are pretty blunt tools when it comes to diagnosis. So it's not surprising that back in the 1980s and even the 1990s, there was still a lot of guesswork going on with trying to work out what was going on. Despite CT scans and their very beautiful definition, sometimes it still does not give us an absolute diagnosis, because unfortunately not everything follows the rules of textbooks. So for these people where the scan is not helpful, the blood tests have not given us more information, some people may need to go on and have a lung biopsy. And lung biopsies we try not to do on people if we can avoid it, because there's invasive surgery, can cause pain, it can cause time in bed and impact on your breathing. So if we can avoid it, we do, but sometimes we have to just to get more information. And you can see this composite word at the bottom, the clinical, radiological, pathological diagnosis. So that's how we come at interstitial lung disease. And that's what all of the world guidelines tell us we should do. So to diagnose a particular ILD, we need to know the clinical information, we need to know what the radiology tells us, and we need sometimes to get a lung biopsy, and that is what we call the gold standard for diagnosing this condition. But I like to know a little bit more when I come at a condition about what's going on beneath the surface, what's going on under the microscope. So these are obviously some lungs, and if you look very closely at lungs, you can see tiny, tiny little branching airways, and we call alveoli. They look like little little sacks of grapes, and that's where all the oxygen and carbon dioxide passes back and forward. Little blood vessels surround those alveoli, so you breathe in the air, the oxygen goes in past the alveolar wall into the blood vessels for your body to use, and carbon dioxide goes out, which you breathe out. So this is what your lungs look like if we look at them very closely. In fact, there's so much surface area for exchange of oxygen and carbon dioxide that you could cover a tennis court with your own lungs in terms of that surface area. So every individual has a tennis court worth of area for oxygen and carbon dioxide exchange. So the lungs are amazing, and it saddens me to hear that 37% of Australians don't think that it's important, because this is basically the thing that's keeping us going. So looking even more closely under the microscope, this is what normal lung looks like when the pathologist has a look at the biopsy. So a normal lung, these are all the little alveolar spaces in 2 dimensions. So all of that white is basically just space for oxygen and air to enter in. And all of those little pink lines are what we call the interstitium. So this is what we talk about, interstitial lung disease. That's where it affects, that interstitium. And you can see that dotted around are little blood vessels. I mentioned that blood vessels surround all of these alveoli, and they're the blood vessels that take up the oxygen and take it to the rest of your body. And this is what interstitial lung disease looks like. So you can see that that interstitium is incredibly thickened, really thickened. And what is all of that pink stuff? Well, some of it's collagen, which is scar tissue. Collagen is what our body creates to respond to injury. And that's the scar that you would see. Even on your skin, you've got collagen that's become scar tissue. And all of the other little dots, the purple dots, are probably cells that are driving that collagen deposition, or perhaps inflammation cells that have been recruited because of some sort of injury that the lung is having to deal with. So what happens when normal lung becomes inflamed or scarred? How does that actually affect you? What's going on at a sort of a mechanistic level? So normally, this is my little oxygen molecule up on the far right-hand corner. Oxygen will pass from the outside environment down into your airways, down into the alveoli, and will pass into those little blood vessels within a fraction of a second. So you breathe it in, and then immediately they go into that blood vessel and it's whisked around to the rest of the body. And all this happens within about a quarter of a second, so no time at all. In interstitial lung disease, you breathe that oxygen in, but the passage is a lot thicker, so it's got a lot further to travel, and there's a lot more resistance to that passing of the oxygen into the blood vessel. So that can take more than a quarter of a second. It can take 3/4 of a second or even longer. And it's the time that it takes for that oxygen to pass into the blood vessels that will actually be reflected in what your oxygen levels are when we check it on the oxygen probes. Because if you're not able to get oxygen in quick enough, then the blood that your body sends around to the rest of your body is not going to be loaded up with as much oxygen as it needs. And so when we're measuring your oxygen level at the finger probe, it might tell us that your levels are 89% or 92%, and whereas they should be 97, 98 or 100%. So that's basically what's going on at the most fundamental level. So we distinguish IPF from other forms of interstitial lung disease because they have different, we believe now as a medical community, different mechanisms of how they develop. So this is really how we consider what's going on in most forms of ILD. there's some sort of insult, be it an infection, be it a bird feather, be it trauma, be it some sort of toxin, chemotherapy, or even an autoimmune disease like rheumatoid. That insult will then trigger your immune system to respond. And not everybody's immune system will respond in the same way, but for certain vulnerable individuals, this immune system response will be a little bit too exuberant. And with that exuberant immune response, lots and lots of inflammation will occur, which can lead to, ironically, to tissue damage. So the immune system is not really meant to cause damage, it's meant to protect us. But sometimes it's a little bit too exuberant, and all of the effects of that inflammation can lead to long-term tissue damage and scar tissue, so laying down of collagen. And so when we look at treating most forms of interstitial lung disease, we try to stop that insult from happening. So that might be telling people that they need to, sadly, pass away, leave their birds, give them away. So that's a very common thing we tell people. I'm sorry, but you need to send the budgie to another home. And also, at the same time, we also need to be dampening down that very exuberant immune response. And that's why we treat a lot of people with immune suppressing drugs. And Suzanne's going to talk a lot more about how the strategies involved with that. IPF is different. And we only know this, we've learnt this the hard way, because we used to treat all people with IPF by targeting their immune system. And what we discovered is that it didn't work. And not only did it not work, but it was actually harmful. So now with IPF, we do not treat inflammation because it doesn't occur, or it doesn't occur very much. We don't really know what the insult is. We're still learning about that. But our therapy is now targeting that scar tissue directly. So we are treating people with IPF now, and this is only in the last 2 years or so, with antifibrotic therapy, as opposed to immune suppressing therapy. And as I said, Suzanne will be covering this in a lot greater detail, just to talk you through how we've learnt these lessons and what this means to people. So the point I'm making is that IPF is different. It's a primary scarring process, as opposed to a lot of other ILDs where there's some sort of inflammation which then ultimately leads to scar tissue if you don't get to it in time. So despite the very many diagnoses, the 200 or so different diagnoses, surprisingly, the symptoms are very similar in everybody. And we know that these symptoms are what's taken you to your doctor in the first place. These are the symptoms that are impacting on your quality of life. And these are the symptoms that you're desperate to treat. Breathlessness is one of the key, is the hallmark of the condition. I've already shown you how that interstitium will be affected, how it gets very thickened, and how that impairs oxygen transport. So that's one reason for breathlessness. And so that scarring can occur when that lung tissue becomes damaged and scarred. Not only is oxygen having difficulty passing from the air into your body, but in addition to that, when you've got lots of collagen, it's not very stretchy. Collagen is quite rigid. And so your lungs, which normally can expand to take in 6 litres or more at the top of the breath, can no longer expand as much because of that collagen, which is now quite a rigid structure, preventing your lungs from expanding. And so that will increase that work of breathing and that sense of difficulty when you're trying to take deep breaths, and that will also lead to breathlessness. What about cough? Cough is the bane of many people's lives, and I'm sorry to say that we don't yet have a very rigorous way of dealing with it from a medical point of view. I think that cough is one of the hardest symptoms to deal with, and today you're going to hear about some strategies for treating these sorts of symptoms from other speakers. But I believe that we as a medical community need to be able to come at this with a more rigorous approach, and we need to deal with this better. This diagram here that you see shows that there are lots and lots of different cough receptors throughout your lungs and also in the upper airway. These are those little black dots that you see. So these cough receptors are triggered by inflammation and also by stretch. So when you have a fibrosis or a scarring going on in the lungs, it is a potent trigger of cough. It sets those cough receptors off. And you actually have a cough centre sitting here in the back of your brain, which will be constantly receiving signals from these receptors telling you to cough. You could say, well, can't we just cut that reflex? Can't we just somehow put a block in there and stop those signals going up? Well, that would be fabulous if we could do that. There are some medications that can dampen down that cough reflex. So for example, morphine type drugs, anything that contains codeine. Some of you would have tried codeine linctus or have even had some morphine, and that's a really good dampening down of that cough reflex. Again, that's going to be discussed in a little bit more detail later on. But still, we're doing lots of experiments in different novel drugs that may be able to block that pathway. Additionally, and this is perhaps underappreciated by even doctors as well as you guys, but there are so many other factors that go into a chronic cough that have nothing to do with your ILD. Reflux is a major symptom in the general community, but it's also thought to occur with a greater frequency in people with ILD. And reflux, you may not even be aware of heartburn, but you can have silent acid going up from your stomach, up into your esophagus, trickling down into your airway, particularly at night time. And all that acid from the stomach contents, of course, is going to trigger your cough. All those reflexes hate acid. So of course that's going to trigger cough. And a lot of times medical people will give you anti-acid therapy to try and see if that will help reduce the cough in any way. And it can be quite an effective strategy in some people. Postnasal drip. How many people have postnasal drip in this room? Yeah. And it's because we live in Australia. I mean, there's so much going on in our air, in our environment. There's pollens. It's a dry country. We've got a large prevalence of asthma anyway, and what we call atopy. So a lot of people who are responding to all these signals that the environment is sending us. And so it's our body's natural want to create mucus. And so all of that mucus will drip back down into your throat, down into your lungs. And when you cough up all that muck in the morning, that's probably come from your sinuses. And of course, as I said, asthma is a common condition, so a lot of people will have that as well as their ILD, which causes cough, and infection. You'll all be very familiar with this and how this interacts with your disease. Weight loss, again, is an issue that many people struggle with, and they wonder, why am I losing weight? And this is something, again, that can be quite hard to treat. The converse could be true, and we talk about the side effects of medications is my second point. So steroids, a lot of people will have had a lot of interaction with steroids, and weight gain is a major problem with steroids, as many of you will have been aware of. But the converse can be true, where medications can actually cause nausea and can cause a lot of difficulty wanting to eat. You don't feel like eating. And not only that, you're actually burning up a lot of energy just by breathing, a lot more energy than you would normally. And that can get that balance that you see there towards weight loss, because you're expending more energy than you're actually taking in. So I've already covered all of these things, but these are the risk factors that we look for. And a key question that many people will want to know the answer to is, if family history is important in my disease, will this affect my children or my brothers and sisters? And I think that the answer is frequently no, because the conditions are not inherited in a very common fashion. So although having a family member with an ILD increases your own risk of developing ILD, it is not the main reason that you will develop an ILD. So it's an important thing to know that your mother or your father has a particular ILD, but it's not going to mean that you need to be going and getting a CT scan every year for the rest of your life to look for these conditions. You can see that less than 5% of IPF cases are familial. So most cases occur sporadically, which means that there's no rhyme or reason, there's no family risk. Exposures, of course, I've already covered a lot of those things, and I won't revisit them at the moment because of time. So after diagnosis, what happens next? Well, it really depends on your particular disease, as well as that disease behaviour that I talked about. Because even though two people may have the same diagnosis, their diseases may behave extremely differently. And the only way that we can learn about how your disease is going to behave is by following you closely. So at our clinic, we like to do 3-monthly clinic review and lung function testing, comprehensive lung function testing. We also want to know from you about symptoms, and if symptoms are occurring between clinic visits, we need to know that. If things have changed, you need to re-look at things and change tack sometimes. And Karen is going to cover today a lot of the reasons behind specific testing that are done and what we're actually looking for. Therapy, of course, is the main thing that we as a medical world can offer you, and that may be in the form of entry into a clinical trial, particularly in IPF. That may be through medications, or it may simply be through ongoing close observation. We really can't tell until we know how your disease is going to behave. There are a lot of non-pharmacological strategies which will have a big impact on your quality of life and your symptom burden. And Alyssa Spencer is going to talk about how we can use these sorts of things to our best advantage. I just wanted to flag that occasionally the working diagnosis may change, because sometimes things evolve over time. So a lot of times it's not clear. As I said, there's 10% of people with unclassifiable disease may declare themselves in 5 years from the time we first met you, or 2 years. So you may develop positive antibodies or other symptoms that give us a definite diagnosis. So it's really important to report new symptoms, even if you can't think how they may be related. Symptom management, and sometimes through the aid of palliative care, because nobody does symptom management as well as palliative care. So we really rely on that resource because we know that they do it better than we do. And another speaker, David Currow, today will be addressing how this can be best accessed. And then finally, adjusting to having a chronic condition and chronic symptoms that are with you every day is a very big challenge. And the impact that those symptoms will have on your quality of life is such a personal thing, and how you navigate those waters and how you support your loved one with those symptoms is something that doesn't come very easily. It requires a huge shift in your thinking, and I think strategies and how to deal with that are, I don't think we as doctors do it particularly well. We don't really know how to help people with this in many aspects. Sometimes we don't have the time. And one of our speakers, Brett Toll, who is a psychologist, is going to talk about some of these aspects today. And lung transplant is not for everyone, but I put it there because some people do go on to need that sort of discussion and consideration. I don't have really any more time, so obviously this slide means a whole lot to all of you, but we get to know you very well. We care about how you're going, and so you will develop many close therapeutic relationships in your time. And family and support people will sometimes that can put strains on relationships, but I think that they are going to be your best bet of coping with these sorts of situations. And I'm heartened to see so many support people today, because obviously, these are the people that will be walking the pathway with you. So when you say, what is ILD? This is my final slide. If you went to Dr. Google, then I applaud you, because that's what I would do. And I think knowledge is power, and that's why you're all here today. And we hope that we can help you come at these conditions with greater understanding. And you can see that it's only through research and through advocacy and through inquiring minds and interest that we've been able to make some headway into diseases. What's next? We have greater genetic understanding, stem cell therapy. The future is very bright, and I'm very excited to be part of this particular research field and dealing with it in a clinical sense as well. So thank you.